pure titanium. Other metals are also available for the dental implants, as mentioned in the slide. Then this is the chart. This is about the grouping of the hard tissue replacement materials according to their compatibility of the bony tissue. So the degree of compatibility, whether it is biotolerant, bioinert, or bioactive. So accordingly, they have categorized the various materials. I will share this study material with everyone so that they can go through this. Then as we see, implant design, one should take into the consideration. So regarding this, threaded or screw design implants, these are demonstrated to function for decades without any clinical problems. These provide the more functional area for the stress distribution. And in these cases, there is the minimal bone loss is seen. In case of cylindrical implants, press fit root form implants, these depend on the coating or surface condition to provide the microscopic retention and bonding to the bone. And combination root forms, it is the macroscopic features of cylinder and screw root forms. So this is the regarding the implant design. Regarding the threads, the dental implant applications dictate the need for the thread shape optimized for the long-term function, load transmission under the occlusal, intrusive, and shear loading. So in this, what is to be taken into the consideration is the thread geometry. In that, thread shape, pitch, and thread depth. So as a clinician, it's not very much important for us to go in all these details, but the manufacturing company, they have to take into all these things into the consideration. Grooves, there grooves on the threads of all the implants and on the collars wherever it is appropriate, and these grooves increase the surface area. So motto is that to increase the surface area of that implant surface, so that there will be the more bone to implant contact. So there will be the successful osseointegration. So regarding the implant surface, the extent of bone implant interface is positively correlated with an increasing roughness of the implant surface. So roughen the surface, there is the greater bone to implant contact at the histological level. Micro irregularities, they increase the cellular adhesion, and high surface energy, it improved the cellular attachment. So these are the various methods like electropolishing, sandblasting, then titanium plasma spraying, acid etching to increase the roughness. The two materials plasma sprayed onto the implant are the titanium and hydroxyapatite. So advantages of hydroxyapatite, there is the faster healing bone interface, stronger interface, then less corrosion of metal. Okay. So basically, there should be the as great as surface area. Regarding the implant design, there should be more threads, more grooves. Then the next factor is the state of the host bed. Healthy, and within the ideal host bed is that host bed which is having healthy and adequate bone stock. So we have to take into the consideration bone height, width, length, and density. And which are the undesirable host beds? If there is the previous irradiation and ridge height resorption. Okay, so we have to take into consideration whether the patient had undergone radiation therapy, because in some cases they might have undergone radiation for the oncology treatment, and usually in old age patient there is the problem of ridge height also. So these are the undesirable host beds for the implantation. 10 to 15% poorer clinical results. These must be anticipated after therapeutic dose of irradiation, vascular damage, at least in part. Okay, this is regarding the radiation patients. Such clinical states may constitute an indication for the ridge augmentation with bone grafts. So in such cases, first of all, we have to do the bone augmentation, ridge augmentation with the bone grafts, and then we can proceed. Then we have to select the suitable implants depending on the quality and quantity of the available bone. And what surgical considerations we have to take into account? The main aim of the careful surgical preparation of the implant bed is to promote the regenerative type of the bone healing rather than the reparative type of the bone healing. Okay, the motto is to promote the regeneration. The critical time temperature, then bone tissue necrosis, it is the 47 degree for 1 minute. Then recommendations by the Erickson. So Erickson, he had proposed some recommendation to achieve good osseointegration. That there should be slow speed of the instruments. Then adequate cooling, avoid overheating, bone cutting speed less than 2000 RPM. Then tapping at a speed of 15 RPM with the irrigation. And operators should use the sharp drills. Regarding the loading conditions to achieve good osseointegration, there is the progressive or two-stage loading, and second is the immediate or one-stage or non-submerged loading. Progressive or two-stage loading, Brainmark et al. To accomplish osseointegration considered the following prerequisite. Countersinking the implant below the crestal bone. Okay, all of us know this. Then obtaining and maintaining a soft tissue covering over the implant for 3 to 6 months and maintaining a non-loaded implant environment for 3 to 6 months. This is regarding the two-stage loading. Then elements of the progressive loading are the one have to take into consideration time interval, patient's diet, occlusal materials, occlusal contacts, and prosthesis design. The healing time between the initial and second stage surgeries for D1, D2, D3, D4, these are the bone qualities that we will see in the further lectures where we are going to discuss about the radiographic examination before the dental implants. So right now just try to understand that if D1 and D2 in this 3 to 6 month time is required and D3 and D4 5 to 6 months. This will be covered in detail in the radiographic examination for the dental implants. Then the dentist controls the diet of the patient to prevent the overloading. In initial healing phase, patient should avoid chewing in the area and soft diet. We have to advise the patient for soft diet. After evaluation of the final prosthesis function, occlusion and cementation, we can advise the patient to have the normal diet. Till that, he should take the soft diet and should avoid chewing in that area. In initial healing phase, there should not be occlusal contacts and there should be implant protective occlusion concept. So there should not be any heavy occlusal contacts in that region. So we had this was about the two-stage loading. Now the immediate loading, it is the non-submerged one-stage healing. It loads the implant with a provisional restoration at the same appointment or shortly thereafter. It reduces the risk of the fibrous tissue formation and minimizes the woven bone formation. It promotes the lamellar bone maturation to sustain the occlusal load. Then it enhances the bone remodeling and increased bone density can be seen. So this was the progressive loading and the immediate loading. Now we will see the last part of this osseointegration, methods of evaluation of osseointegration. So till that we have covered the everything like introduction, definition, history, theories, mechanisms, and types. And now we are going to see the methods of evaluation of osseointegration. So stability, it is the requisite characteristic of the osseointegration. And initial stability, it is the function of the bone quality, implant design, and surgical technique. Now regarding the bone quality, how it should be assessed. So as I told that whenever any implant patient will come to you, first of all, you advise him the radiographic examination. In that you can assess the bone height, width. So that we will see in the radiographic examination topic. Implant design, we have seen already how the implant design is planned for the good osseointegration. And surgical technique, that will be also covered in the surgical lecture part. But right now we had seen the some points that we should take into consideration to get the initial stability. During the osseointegration healing and maturation process, the initial stability changes with increase in the bone to implant contact and osseous remodeling. Then invasive methods like histological sections, histomorphometric, TEM, that is the transmission electron microscopy. Then by using torque gauge also we can assess the osseointegration. These are some invasive methods. And non-invasive methods like percussion test is there, tapping is there, radiographs. By this also you can assess the osseointegration. Then perio test, it is the reliable method to determine the implant stability. So this is the electromagnetically driven and electronically controlled tapping head that hammers an object at the rate of the 4 times per second. So this is that instrument. By using that you can assess the osseointegration. So as this Miller's index, it suggests the maximum mobility, and the 0 Miller's index, it indicates the maximum anchorage. We need the maximum anchorage. Radiographic evaluation, non-invasive, it can be performed at any stage of the healing. Bite wing radiograph, it measures the crestal bone level. So 1.5 mm of CBL, the crestal bone level, it can be expected in the first year of loading with 0.1 mm of subsequent annual bone loss. So this is how you are going to evaluate it radiographically. You can also assess the by the probing depth, and it is the excellent method to assess the health of the natural teeth. In implants, little diagnostic value unless accompanied by signs and symptoms. So in stable implants, the pocket depth is about 2 to 6 mm. Okay, and it indicates the bone loss, but not necessarily any disease, or we can say any deformity is there. Okay, it indicates the bone loss. And sulcus depth, which is greater than 5 to 6 mm, there is the risk of the anaerobic bacterial infection in that. So probing depth, it is the easy and very good diagnostic method. So conclusion of this topic, as the concept of osseointegration, it has developed and spread globally. It has had a dramatic impact on the practices of dentistry. So in implant dentistry, an undisturbed healing period, it is always required to ensure the osseointegration. A modified protocol with an early or immediate loading has been tested to satisfy the demand of more rapid treatment and to reduce the discomfort of wearing removable appliances during the healing period. So provided that the implant has a primary stability, studies have shown that the survival of loaded implants, it can be analogs to the unloaded protocol. So this is the conclusion of our today's topic. As it was completely theoretical topic, it might be some people have found it very boring, but it's very important because one should know the basics first, then we can go to the surgical part.
Yeah, you've done, ma'am?
Yes. Yes.
No,
Ma'am,
it
one
was.
question.
Yeah. Yes.
Ma'am, in case of full mouth rehab cases,
Yes.
are those are in majority resolved cases, and in knife edge flavidages, which type of implant you preferred?
Yes. Actually, today's topic is only regarding the osseointegration. I think full mouth rehabilitation, the another topic will be there. Because surgical part, we are going stepwise. Like first of all, we had covered the introduction, now osseointegration. And I think now the radiographic clinical examination and then the surgical part will be there.
It's come under D3 or D4 now, ma'am, bone.
That's only I'm telling ki we are going stepwise.
Okay, ma'am. Thank you.
Yeah. In further topics, it will be covered.
Sir, you are muted.
Sir, you put that question in the group, WhatsApp group. You're there in WhatsApp group?
Can kindly share the link. I'm from ADC exam group. Actually,
Yeah. I'll add you to the group. What's your you
yeah.
hi on my number. I will add you to ma'am's group. You put that your question, and
Okay.
if anyone else is there, last time also one question was there. All questions will be gathered, and whenever the topic will come, ma'am will give you consultation.
Okay.
Okay.
Thank you, sir.
Welcome. Anyone else who wants to ask? Okay, fine. Then, if anyone has any questions, you can put in the group. We will collect all the questions all together.
Yes, you can post your questions in the group. Whatever are related to the topics cover yet, that I will answer immediately. And whatever are further topics, that we will answer it once that topic is covered, so that everyone will understand it.
Okay.
Yes.
Dr. Kostovkar, your number I will save and I will send you the group link and ADC group link also. Both the links I will send you. Don't worry. I have noted your number. Thank you. Anyone else wants to ask anything or any help? You can put in the group. Thank you very much. We will end this. Wish you a very happy Sunday. Take care.
Yes.
Thank you, ma'am.
Thank you so
Thank
much.
you for a wonderful presentation. Thank you.